As you can see, we have seen, it was probably worthwhile for you to stay. We have seen 3 brilliant presentations. And what I like to do, we have 5 or 6 minutes left. Is ask Thomas and Stephen, if you don't mind to come up here, and then ask the audience for questions or comments. And maybe you can share your experience and your knowledge with all of us. And if you have a particular question for a particular speaker, please say so. And if not, we'll a general question to the whole panel. Don't be shy. We have 5 more minutes. Yes, there's a microphone there, although we are here in an intimate crowd. So. Thank you all for your talks. How do you manage the vanishing lesions? Because it's very distressing to claim that it's all gone and then have the surgeon phone and say, what are you talking about? So how do you actually report, and what do you communicate to your clinicians, and how do you manage this situation?
I think it's a very interesting question. Our approach to it, we don't have one unified approach, and I think it changes from one patient to another. I think if you can resect the bit of the liver where that was, you should probably do that. So I think you should stick to your original plan. So if you give someone chemotherapy with the point of view of, or with the intention of making them resectable, and they then become resectable, you should probably go ahead and resect. But there is evidence to say that that just waiting is potentially just as good as resection. But I think that's certainly been our approach, and also to the extent of trying to do things like portal vein embolizations to make the hepatic remnant big enough to allow that kind of surgery in a situation where it wasn't initially resectable. But I think then if you can't do that, if you can't resect the part of the liver where the lesion was, and you can't identify it with intraoperative ultrasound to do an intraoperative ablation, it is still potentially reasonable to resect other metastases that are visible and leave that one behind. Because I think the data would suggest that depending on which paper you look at, something between 30 and 80% of disappearing liver metastases still have tumour in them. But then you're taking the potential chance that you're in the other side of that, so I think it's potentially a risk worth taking. There isn't a good alternative.
I agree with that. But one of the greater problems I have, and I'd like to share with it, is to what degree do we change the surgical planning? Because one of the lesions, for example, the patient has 5 metastases in the right lobe, and then had 1 in the left lobe. And the 1 in the left lobe has disappeared. And you can still see the ones in the right lobe. Do you then say that, well, we'll just go and do the right side and wait for the other one and see what happens? I mean,
yeah. I think that's not an unreasonable approach, but you could also use intraoperative ultrasound to try and find it and then get Thomas in to ablate it intraoperatively, I think is a reasonable approach.
I think one thing we have to consider, so we have this point quite often in the tumor board, and the surgeons are pretty reluctant because normally the chemotherapy regimens that a patient experienced before are complex ones, and they are dealing with the blue liver. So they do not really like to do surgery on the blue liver. So in many cases, it ends up with some kind of somewhere in between wait and see, and if they're tiny recurrence, we go for a local ablation. In most of the cases, indeed, in percutaneous ablation. We have the problem if you have a responding lesion that is identified with functional MRI, and we're doing the ablation under CT guidance. Ultrasound, normally you never see it, and under CT you don't see the lesion. So you have to do some kind of weird trigonometric tricks, and to do the next day the control and see you have exactly been beside the lesion ablated, so you have to do another one. So this is another task with the vanishing lesion.
I want to share with you my experience. I serve in the liver tumor board in our center, and this is a common problem, and the answer to you is it depends. Famous words. It depends on the specific patient. It depends on the specific lesion. But obviously, if you don't see it with a couple of methods, it's very hard to chase it. And the point is to tell the patient, tell the clinicians, the proverbial disclaimer. We don't really know if it's gone or not. We just don't see it. And you realize how blunt is our instrument. We don't really have a microscope, as was mentioned. And, you know, if you don't see it with MR, if you don't see it with PET, if you don't see it with CT, with good contrast, you just have to wait and follow and hope for the best. But I think we have exhausted our time. This was a good session. Thanks so much. Have a very good trip back to your homes, and hopefully we'll see you next year. Thanks very much.
Thank you very much.